We then realized that it may not be a good idea and not possible to go to different places and do the programs every time. So we started with the e-learning, starting off with the free YouTube videos. And there are over 400 videos which are available freely in that perspective. And these videos basically are accessible to across the globe. And a lot of people have been accessing these videos over this time. And as we are looking at currently, there are a lot of people who are subscribing even to this program as well. So there are over 1.5 million views which have been given in these videos in terms of this e-learning program. We then realized that we needed to have a structured program rather than just having some videos. So we started off first with a fellowship program from 2017. And till date in the Regency Center of Diabetes Endocrinology and Research, we have had 11 fellows who have been involved. And I remember Dr. Kapoor, when we went for the first time, and he said that, yes, we should start the program. It was one of the few centers which started the program at that point of time. So in the last 7 years, continuously, we have got very good fellows and with good support from the hospital. In 2018, we started the online learning portal MedEClasses, and then a lot of books and application came up. So we have got pediatric endocrine learning tools. We have got fellowship programs in pediatric endocrinology, a 2-year course. And many of the people who are here actually are part of that course. They are coming 4 times in a 2-year period to gain experience, clinical, as well as learning in that perspective. We have developed the MedEClasses endocrinology app, which I was talking about. It's the most downloaded pediatric endocrinology app with over 5,000 installs, a lot of publications coming onto it. We are working in terms of developing connected clinics, which will help out people develop personalized care in terms of specific disorders. So we have developed tools to guide evaluation for growth failure, which have been validated. There are tools for management of diabetic ketoacidosis, which have been shown to reduce the complications of DKA. We have developed a bone age application, which provides within 2 minutes a reliable and valid way to assess bone age, which has already been published. A lot of other interpreters are there, which are being published, include our obesity interpreter, our puberty interpreter, as well as thyroid interpreter. So these interpreters are going to make life very easy. You have to enter the values and you will get the right outcome. And they have been validated in a large number of patients in that perspective. We also developed a DSD interpreter. And the next step, which Vibha was talking about, was the bone age assisted interpretation of growth, in which all the pediatricians have to do is to enter some basic information with regards to the child in terms of their age, in terms of their birth weight and other parameters. And then you have to enter about their pubertal status. And then you can either have a manual entry of bone age, or you can have a data which you have to select the sites and get the right data in terms of bone age. Now, this bone age assisted interpretation of growth is a tool we have been using and validating for the last 1 year in our center. And this has been found to be perfect in terms of not only plotting the data, but also getting a lot of interpretation and whether our puberty and growth is going normal or not. So this is going to be probably a way in which we can really screen a large number of normal children, as well as patients who are coming to different pediatricians in terms of school, as well as clinic, to get the right guidance in terms of evaluation and management from that regards. So we have got different courses. We have on-site course. So we have had 7 on-site courses till now. And yesterday we had a big number of around 48 participants from across the world actually, and over 300 patients who had come from different parts of the country to specifically come and get exposed in this perspective. We have got multiple publications, and we have now coming up today with the 2nd edition of MedEClasses Basic Pediatric Endocrinology, that many of our patients require genetics. But again, which test to do, when to do or not do, how to interpret is also very important. So now I think endocrine genetics is coming as a big way in that regards. So when do we order a genetic test? For screening, establishing a diagnosis, saying a prognosis, and do again, as I said, only if you are going to change your management based upon that and do a clinical correlation in that perspective. Now, remember that all diseases do not have a genetic etiology. Manoj was talking about that child with constitutional obesity. If you do an unnecessary genetic workup there, it is not going to help out. So what we need to remember is that depending upon the penetrance and prevalence, you will have 3 basic group of disorders. Mendelian disorders who are highly penetrant and they have got very less prevalence. While you have got the complex traits like obesity, short stature, You may also have things like diabetes, in which you have got high prevalence, but the effect of a single gene is less. This is a polygenic inheritance. So what we are mainly going to focus are about these Mendelian group of disorders, and not these complex traits where doing a genetics is absolutely useless from that perspective. And we talk about various type of inheritances. We'll mainly be focusing about monogenic inheritance, largely Mendelian, and the exception that are there in terms of non-Mendelian inheritance. And we've got some very interesting cases to come up with.
So the first case of a 3-year-old boy who presented with achondroplasia, and the family was unaffected. So, sir, we know that it is inherited in autosomal dominant fashion. Do you think the family can be unaffected in such patients?
Yes, this could be theoretically a novel mutation. So that's why the family is unaffected and the child had a mutation. Now the question is, he is asking whether the next child will be affected or not. So what would you counsel?
If this is a novel mutation, maybe perhaps not. The chance of recurrence will be as much as the baseline population.
So like some new mutation will be like a very, very rare chance that the second child will also have a mutation. But what happened here? So this is the classical autosomal dominant, in which you will expect to be parents should have been involved. Since the parents is not involved, we are saying this is a novel mutation.
So what happened was this: the index child was affected and the family was not affected. So the possibility of a novel mutation was considered. The family was reassured that there is no chance of, or the baseline chance of recurrence in subsequent sibling. But the next child also developed achondroplasia. Now, how do we explain that, sir?
So this is a very, very unfortunate scenario in which they were counseled that nothing will happen, but unfortunately they developed it. So we need to understand that there are multiple factors which affect the Mendelian inheritance, and one of them is mosaicism. So mosaicism means that all the cells do not carry the same genotype. Different cells will have different genotype. So here what may have happened is the gonads of one of the parents had that mutation of achondroplasia, while the somatic mutation was not there. So that's why it passed on to the next generation. And so therefore, whenever you have this sort of a scenario, you should always be wary that there could be a germline mosaicism. So always in these sort of conditions, you have to be careful before you say, okay, everything is normal. Maybe getting a genetic testing in the intrauterine period may have been a good option in that regards.
So the second case is a 2-year-old girl with vaginal bleeding, had recent onset breast development with no pubic hair. On examination, she had irregular cafe au lait spots with ovarian cysts. Now, this made the diagnosis of McCune-Albright very classical presentation of McCune-Albright, and the lab parameters collaborated in form of low LH-FSH levels. However, GNS1 testing was found to be negative sent from the blood sample. Now, how do we explain that, sir?
So again, this comes out back to the mosaicism part here again, because what we're looking here is that McCune-Albright is a somatic mosaicism. So some cells will be affected, some cells will not be affected. So blood sample may be negative. How many of them will have blood positive usually?
How many?
So it's like 50% around may have a positive in the blood. But if you are negative in blood, this does not exclude McCune-Albright. Then you take the sample either from the fibroblast, cafe au lait area. You can take from the cyst aspiration, you will get the right report. Same is true for Turner syndrome, because Turner syndrome, if you have a mosaic Turner and you don't do enough number of karyotypes, you will be missing out in terms of this Turner syndrome. So this is very, very important. So this is a somatic mutation, and we should look for the site where it is affected. So cafe au lait is the best area to do a skin scraping at a fibroblast. You will get the diagnosis.
Next is a 5-year-old girl presenting with hypocalcemic seizures. The lab evaluation showed hypocalcemia with hyperphosphatemia, normal creatinine. PTH level was inadvertently low for the level of calcium. Now, someone went ahead with she also had complaints of growth failure. Now, the treating physician went ahead with genetic testing, which showed a RET1 mutation, and there was no family history of suggestive of medullary thyroid carcinoma.
So we are all scared with the RET1 mutation. But what we need to understand is that RET1 mutation in a family who has got 10 people with thyroid carcinoma will have different implications as considered to the RET1 mutation in an incidental diagnosis. Now, we know that you can have pituitary incidentallomas. But if you have features of Cushing syndrome and you have a 6 mm lesion, you say this is significant. If you have no feature, your 6 mm lesion becomes significant. So again, this is an incidental finding. If we do the NGS of all of us who are sitting here, we will find 15 to 20 pathogenic mutations. which are there in us, but they are not manifesting because there's something else is countering it. So maybe somebody is producing more cortisol, but the receptor is down. So things will balance out. So we don't know in this case whether the risk is the same. And this brings us to an important issue of penetrance. And this clearly is a penetrance which is there. So when you talk about two terms, penetrance and expressivity, what are the difference, Dhwani?
Penetrance is
how many of the children will have the disease, and expressivity means how severely they are affected. So you can have variable penetrance in that only 6 of 10 have a disease. You may have variable expressivity in that they may have mild, some may have severe, that sort of a thing, or you can have a combination of the two. So that is important for autosomal dominant disorders.
Next, we have a 10-year-old boy with obesity. He was normal till age of 3 years and had rapid weight progression ever since. There was history of hyperphagia and a small phallic size. The syndrome classically fit into the clinical picture fit into Prader-Willi syndrome. So the clinician went ahead with fish analysis, which was found to be normal. So do we exclude Prader-Willi in this child, or do we go for some other tests here?
So we need to understand the genetics as to what is causing Prader-Willi syndrome. This is an imprinting disorder. So when you talk about imprinting disorder, it means that
there is something that is silencing or modifying the expression of the gene.
And the expression of the disease will depend upon whether you are getting it from the father or from the mother. So imprinting disorder, suppose you have a deletion, 60%, okay, you will be able to pick up on fish. But there are problems in the methylation center, there are problems in the epi-regulatory center, and they will not be picked up on that. So you should know what diagnosis you are talking about. So there you have multiple diseases are imprinting. We talked about Prader-Willi, Engelmann, Beckwith-Wiedemann. And in all these disorders, you need to remember that you can have manifestation depending upon which parent is giving you that particular gene. So what you need to do here is to go ahead with a methylation study, which is a much better technique, and you combine with MLPA, which will give you the diagnosis. So the recommended test for Prader-Willi is methylation study plus MLPA. Fish is not the good test.
Next, we have a 21-days-old boy with irritability, has mild dehydration, very high calcium levels, and high PTH for the level of calcium levels. So this looks like hyperparathyroidism. The urine calcium creatinine ratio is low, again favoring the diagnosis of hyperparathyroidism. Now, is there something that we can inquire clinically about the family, which will help us pinpoint the diagnosis in the next child?
So you have a very high level of calcium in the child, but the urinary calcium is not high. Relatively not high. So what it means is that you have got high levels in the blood, low levels in the urine, which means that the body has a problem in sensing calcium. It is telling my calcium is low, so PTH is working overboard. It's also conserving in the urine. So this is what is known as neonatal severe hyperparathyroidism. And this is often because of a homozygous mutation. Both parents will have a familial hypocalciuric hypercalcemia. So you should basically evaluate. So best would be to look at calcium, phosphorus, PTH in the mother and father. So what did you find there?
What we found that only the father was affected. He had high hypercalcemia, and the mother had normal serum calcium levels.
So that's a very interesting scenario. So normally for neonatal severe hyperparathyroidism, we say surgery. There's no other way, you have to treat the surgery. But this is a unique situation that only the father is affected. So what is happening is that this child has a mutation in the calcium sensing receptor, which is hetero or homozygous?
Heterozygous.
But he is sensing mother's calcium is low because he wants calcium to be 11. Mother's calcium of 9 is low, so he'll develop hyperparathyroidism. But what will happen after some time, once he is out of the placenta, he will then have normalization of level and behave now like a calcium sensing receptor defect. So before you label somebody as neonatal severe hyperparathyroidism and you say go ahead with surgery, you should always exclude this very, very important entity of neonatal hyperparathyroidism, in which only one gene is affected, and that is coming from the father. Mother's gene is normal. So do you think this is an imprinting defect? This is a pseudo imprinting, because imprinting means that this is not an imprinted gene, but this is behaving differently based upon the parental expression. So this is.
Had the mother been symptomatic, would the child have, had the mother had hypercalciuria and the father been normal, will the child present
normal? But the child will have a familial benign hypercalcemia, but he will not have severe hypercalcemia. Another example is GCK deficiency. where you have a problem in glucose sensing. Father is affected, mother is not affected, you will develop
Hypoglycemia.
Hyperglycemia. Basically, because you will try to build up more. Mother is affected, child is not affected, you will develop infant of diabetic mother-like picture. So I think this is beyond that, but a similar scenario.
So next we have a 7-year-old boy with growth failure, height severely compromised, and similarly the weight was appropriate for height but compromised for age. Classically had doll faces and a peak growth hormone level on stimulation test of 2.1. So this fit into a growth hormone deficiency. On examination, he had a firm hepatomegaly with very high SGPT levels. And on an overnight fast, the blood sugar in the morning was 32 with a ketotic hypoglycemia.
So this was the case whom Sajali had presented in one of our conferences. A child who was labeled as growth hormone deficiency, but actually is GSD. Because if you look at it, he has a plump face, he's hepatomegaly. And now we know that GSD, this could be GSD3, this could be GSD6, GSD9. So what we were doing earlier, send one single mutation. Look for GSD3. Now what we are seeing here is that that mutation clearly is negative. So what could have been done better in this scenario? So this is what is known as locus heterogeneity. When we say locus heterogeneity, it means that you can have multiple genes which are controlling the same thing. If you have XY-DSD, you can have 25 genes which can cause XY-DSD. If you have hypophosphatemic rickets, for example, it can be because of FGF receptor problem. It could be because of phosphatonin or so many other genes. So getting one gene at a time is not going to work. So what should we do? We should go for
the complete panel.
Targeted panel. So in these sort of scenarios, it's always better to go for a targeted panel.
Next, we have a 12-year-old boy with obesity with weight SDS at plus 2.2, height is again advanced at plus 1.2, has a normal facies and a normal development. Should we go for, do we consider a genetic obesity here? Is genetic diagnosis warranted in this patient or not?
Yes. So we always talk about this, that all 4S. If you have 4S, then think of a genetic cause. So those 4S are
soon, syndromic, segregating, and severe.
So if it is very early onset, not in this case. Syndromic features, no. Family history, no. Severity, no. If you do genetic testing in this child, you will be doing in crores of individuals. So this is not required clearly in this regards. So what about this girl?
In contrast to the previous child, now we have a child with 2-year-old girl with severe obesity, rapidly progressive, had history of hyperphagia. Now in this child, should we go for a genetic test?
What do you think?
Yes, this is again a soon appearing soon, very severe obesity. This child definitely needs genetic
and syndromic features. So hyperphagia is there. So this requires clear evaluation. So it's early, severe, unusual, and then you will find some defect. So you will get the leptin receptor defect. So if you have severe, soon, syndromic, segregatory, this is the genetic test. Otherwise, you will unnecessarily waste the genetic test there in that regards.
Next, we have a day 3 child with atypical genitalia. Has no palpable gonads, Prader stage 4. Ultrasound shows presence of Mullerian structures and the karyotype was 46XX. So this is a 46XX DSD with mildly elevated 17 OHP levels. The baby was labeled as CAH and started on hydrocortisone, fludrocortisone. However, on serial follow-up, the 17 OHP levels remained significantly suppressed, so the doses were tapered and completely stopped. Even after stopping hydrocortisone, the 17 OHP levels remained normal. And what was classical on history was that the Prader staging also remained pretty much static in this child. As a result, the child was counseled, and further on, this child presented at puberty with complaints of delayed puberty. So
again, this test gives a very important message that just biochemical parameters may not be your final clue for diagnosis. We say, okay, XXDSD is there. This girl has slightly elevated 17 OHP. It's easy, CH, lifelong treatment. But look at the 17 OHP. It's not very high. What Dr. Sugandha was talking about, we have to have levels which are much higher. So here you should think of other possibilities as well. And when we thought this should have been a genetic testing should have been done, and then we decide which test to do. This is a very important thing. So if you're looking, your options are either sequencing. You look at the whole gene, you read each and every part of the gene. You can do a comparative analysis. You do a cytogenetic or a FISH or karyotype. Sequencing could be Sanger sequencing versus next generation. So Sanger sequencing is like you are reading each and every word of the book yourself. NGS is like that you have wanting to read the whole 100 books. You have 1,000 people who are reading this page, this page, this page. So they are not very good. They are not as good as you for the editor, but at least they are covering it multiple times. Then you say same page is done by many people. So you will get, okay, you will get some good idea. The depth of coverage will be more. Comparative is array and MLPA. Here you are comparing so many normal phenomena versus disease phenomena. So you know it's normal or abnormal. And then, of course, cytogenetics, we know fish, which will localize your gene, and karyotype, we all know that. So Sanger sequencing, as I said, is like a very meticulous process, but you can't do it for all the genes. You will do it for one particular gene. It will take days for this result to come in. NGS is a rapid technique, but again, rapid means you may miss. So they may make some errors. So that's why it's not that good. However, latest NGS techniques are coming as good as Sanger. So hopefully in the next few years, this will become the gold standard in that regard. So what we do with NGS is that if we want to look at defects, we go through the entire railroad and see what the problem is. While if you're looking basically for particular sites, you will be looking at NGS. So if you have a single gene, only one mutation is there, you will go with hotspot testing. If you have single gene with multiple mutations, you say, okay, Sanger sequencing. You know 90% of CAH 21 hydroxylase is because of this defect. I will only look at that part of the gene. But if there are 100 defects, then you will do the whole gene. Third is that you don't know whether it is 11, this is 17, this is 21. Do a targeted panel in that regards. Then you don't know at all. In that scenario, you will like to do a whole exome and a whole genome sequencing. What is the difference between whole exome and whole genome sequencing?
So, as we know that DNA has two parts, the exon and the intron. The exon part is translated into, transcribed into RNA and translated into proteins, whereas the intron part is not transcribed. This part, even though it is not transcribed, has some regulatory effects on the coding part, and therefore whole genome will give you the information of both introns as well as exons, and whole exome will give you information of only the coding region of
and
the
what
DNA.
Vibha just mentioned in the setting of AIS was that in androgen insensitivity, you may have a problem not only in the coded region, you may have a problem in the promoter, the regulator. So if you do the gene analysis, it will be normal. And then you will say, okay, this is not AIS, but you should do the whole genome sequencing rather than a exome sequencing. So you should know which test to do. This is the most important slide here. And then copy number variations. Copy number variations means deletion, duplications, chromosomal abnormalities. NGS is not very good for copy number variations. You should do MLPA, and that is why for Prader-Willi, you go with MLPA or FISH. So this is how you will decide. And if you want to do thousands of genes simultaneously, you will do an array that will tell you whether your gene is normal or abnormal. So knowing this will becomes very, very important. So now if you have a likely monogenic defect, if it's not there, don't test. 90% of your cases do not require genetic evaluation. But yes, and you know the candidate genes are only 1 or 2, you said I will do a sequencing. If they are up to 10 to 20, do a targeted panel. If it's normal or if it's unclear, then you go ahead with the exome sequencing. And if it's abnormal, you can do a functional study. Often they report as variants of unknown significance. But if you know that this is androgen insensitivity syndrome, it is the mutation is there in the androgen receptor, forget about it. Just because they haven't reported that mutation, they have said VUS, it is not VUS, it is pathogenic. That's where clinical judgment comes. Functional study is not required for everybody. If you know this is VDDI type 2 and the report is the same, don't waste money in doing a functional study. However, if exome is also normal, you have an option of whole genome sequencing. So I think these two slides will give you the real clue about that. So now what we found in this case was that you had this report.
Yeah. So in this child who was not actually a 21 hydroxylase, there was history of maternal virilization, and we went ahead with targeted panel. The genetic report showed aromatase deficiency, likely pathogenic here. Moreover, sir, I would also like you to explain to us what in silico predictions.
Okay, yeah, these parameters are important. So we'll discuss about how will you decide that when you get a variation, is that significant or not? Now, there's a difference between variation and mutation. Now, we don't use the term mutation because mutation means that this is an abnormal or disease-causing thing. So we need to really know whether this is significant or not. We'll go for this case first and then we'll discuss about that.
We have a day 14 child with atypical genitalia. Bilateral gonads were palpable and there was no uterus on ultrasound. So this was a 46XY DSD with reasonable testosterone levels and salt wasting. With marginally elevated 17 OHP levels. So the clinical picture and the lab picture does go in favor of 3 beta HSP.
So this is the XY individual who has salt wasting. With DSD, it's clearly a 3 beta will be the most common thing. Now, this is the report. Now, how do we decide whether a particular mutation is pathogenic or not? So you look at multiple things. One is familial segregation. Do you have multiple family members who are affected and they have the same mutation? And of course, it is pathogenic. Don't worry about that. If the gene frequency is more than 0.1%, I'll go the other way around. If the gene is more than 1 in 1,000, then you will say, okay, this is likely to be a normal variation. You can't have so many diseased individuals. So less than 0.1% will become significant. Then how long this gene has been conserved? They will tell you that this is conserved for 3 million years or much longer, which means it's a very, very important gene. If this gene has been conserved and this child is not conserved, means there is some abnormality is there in that regards. Then you can look at clinical correlation, whether it's fitting into your clinical diagnosis or not. And then you can do a functional study or an in silico model. When you say in silico, which you specifically asked for, this basically means that you will try to develop a model in the computer, and the computer will try to tell you the functionality. So where is the mutation, which point is the mutation, what change happens in amino acids. Then you will say, okay, this is likely to be effective or not in that perspective. So now if you look at this, what they are saying is that there is previously been reported in patients. That would basically mean that this is very, very significant. It has not been reported in 1,000 genome project. That means it's a rare phenomena, and ill silico production is damaging. So all three would mean that this is pathogenic. But just because they are not there does not exclude the diagnosis if you have a good clinical picture.
Moving on, we have a day 3 child with atypical genitalia, Prader stage 4, no palpable gonads, and ultrasound shows a Müllerian structure. So this is definitely a 46XX DSD. The lab evaluation showed hyponatremia with hyperkalemia and very significantly elevated 17 OHP levels.
So this is clearly going like a 21 hydroxylase deficiency, but somebody did a NGS and the NGS was normal. So what do you think is happening here?
NGS is not a good test to diagnose 21 hydroxylase deficiency. Going for a hotspot testing or a Sanger sequencing could have helped.
Why?
Because there is presence of pseudogene which may alter the results of genetic
So when you have, why is it the most common form of CAH? It's because there is a pseudogene and there is an exchange between the true gene and the pseudogene. So when you have a pseudogene, your NGS will pick up that pseudogene also, and that may cause more confusion. So NGS is not a good test for 21 hydroxylase deficiency, which clearly Dhwani has mentioned. You should go with other scenario like Sanger sequencing in that regards.
Next, we have a 15-year-old girl with primary amenorrhea. On examination, she has breast stage 4 with sparse pubic hair. And what we found interestingly was presence of bilateral inguinal gonads in this child. Ultrasound showed no Müllerian structure, so this was an XY DSD picked up at a much later stage. Next, what we found was elevated FSH levels. The karyotype confirmed a 46XY karyotype, and the testosterone levels were significantly higher.
So what are the diagnoses in a XY individual? Primary amenorrhea, good breast development, no pubic hair development, high testosterone, androgen insensitivity syndrome. Yes.
So, however, the whole exome sequencing done to confirm the diagnosis was found to be normal. So what went wrong here?
So this is what Vibha was highlighting, that we need to understand that the androgen receptor, the problem could be in the coded area, or it could also be in the promoter or the regulator area. When you're doing a whole exome, you are only looking at the areas which have been coded. You're not looking at the areas which are proximal to the coding region, and therefore you may have an error. So if you want to really look at androgen insensitivity, you need to go for a whole genome sequencing rather than a whole exome sequencing in that scenario, and WGS would have been a better scenario.
Next, we have an 8-year-old boy with short stature, height of 92, which was at minus 6.2 standard deviation. He was small for gestational age. And as per the new guidelines, we know that pretty much for everybody, a genetic test has been advised. So we went ahead with an NGS and found out the workup to be normal. However, he was found to have 10 variants of unknown significance.
So I think this is a common thing. When you do a MRI in everybody, you will find incidentaloma in 10%. When you do CT abdomen, you will find adrenal incidentaloma in 5 to 10%. Similarly, if you do, as I said, sequencing in all of us, we will find 15, 20 variants which are now confusing. They may cause a disease, but they may not cause a disease. So there are now guidelines in which otherwise they will cause confusion. If suppose you release the report and you say that this patient may have a risk of medullary carcinoma thyroid, you can understand what will happen to the child. He's come for the short stature, but you have given, okay, likely to be medullary carcinoma thyroid when you don't only know whether he is at risk or not. So now there are specific guidelines that there is only a few conditions in which that they will release the report. They will not release the report in every condition, but few conditions are like in endocrinology. I think there are a bit of these hyperlipidemia syndromes and all those which you can easily identify. So this is a guideline. Otherwise, there will be a lot of confusion for the doctor as well as for the patient.
Next, we have a 29-year-old lady who presented with medullary thyroid carcinoma and pheochromocytoma. She was diagnosed with MEN2B. Her sister's son is about 3 months old, and now she's concerned for her nephew's sake and goes ahead with
what you want to testing from that.
Yeah. Should we go?
So this is important. We always talk about what is known as a cascade testing. If you have somebody with medullary carcinoma, you have to look at first degree relatives. You have to screen them. Now, what do we do here? Luckily, we have got very good genetic testing, and there is a very good genotype phenotype correlation in this setting. So what you will know is that based upon what gene is affected, you will know the risk of development. The worst gene is 918, which basically is a bad scenario. So what you need to look at here, the 918, if it is affected, then you have to go ahead with a prophylactic thyroidectomy. So right in the first year, you will remove the thyroid to save the medullary carcinoma from happening in this regards.
Next, we have a 12-year-old girl with incidentally found to have hyperglycemia. The HbA1c was 6.5. Fasting sugars were slightly on the higher side, but 2-hour postprandial levels were normal. She had no ketosis. There was history of early onset mild diabetes in mother and grandmother, which never required major shifting to multiple anti-diabetic agents. She had a normal BMI and no signs of insulin resistance, and being of pediatric age group was started on insulin. With bolus dosing, she had frequent hypoglycemias, and therefore, should we consider something other than type 1 here? And if yes, how do we go ahead?
I think this is a very interesting case. This is a very mild hyperglycemia. Your fasting is very high, but 2-hour value is not going up at all. So there is something wrong. This is not a usual type 1, type 2. This is something else. It's a lean individual, strong family history, no acanthosis. So I think MODY becomes very, very important. And this, if you ask me, we will have a talk on MODY. This is more likely to be a GCK MODY rather than a transcription factor MODY. So now what we should have done in this case is to get a genetics. And genetics will show you this is a GCK deficiency. Now, this genetics is going to help you out. You don't need to give any medicine. You don't need to give any insulin. You can just follow them up over time and get the diagnosis. So the prognosis is predicted via medullary carcinoma. The treatment is predicted. So this is precision medicine, so to speak, in that regards. The key messages are that classical Mendelian patterns are rare. Consider non-Mendelian effects as well. Genetic testing should be done only if it is essential, and method selection is vital.